Med-Surg chapters are about 50 pages long, and half of the time you can't tell what is important. This video will help you to see it all fast. If you are a nursing student, this could save you hours of rereading. And if you are here just to better understand the conditions, I hope this makes the topic feels less intimidating. Hi friends, and welcome back to my channel. I am Nurse Mia, and this is part 2 from the Med-Surg RN chapter, the outline from the Get Zen RN study group series. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters so you can see the full path of disorders, lab intervention, all at a glance. You'll know exactly where to zoom in and what to prioritize. It takes the pressure off and makes the chapter easier to follow. Comment below which section of this chapter feels the most overwhelming for you. The goal? One page of clarity you can revisit in minutes. A map turns 60 pages in 10 minutes of review. Clean path, less noise. You will know where to start and what to skip. Let's get started. So this is the chapter 17 post-op. This chapter is super I'm saying for me was a little bit back and forward a lot, and got a little bit to make a lot of pauses in order to accumulate. So here I can make a little bit. So it's introduction, post anesthesia care unit, which is 2, 3, it's patient care in the post-anesthesia care unit, and this is not 5, this is 4, because I got confused with nursing management will be 4, but actually not, it's in same structure here. And all of them, they talk about assessment, teaching, and here, everywhere. Then this is 4, patient care on the inpatient unit, and here I put again 6 because it's nursing management, so same like here, and this is the same, but it's for this category. So taking my light, and I hope you understand my little mistake here. Introduction. We have the chapters overview of the importance of post-operative care in preventing complication and promoting recovery, and the role of nurses in the early detection of complication, effective communication, and timely intervention. So this chapter is the post-operative period, begins when the patient leaves the operating room, so previous chapter, and continues until full recovery, which will be ready for discharge. So this phase is critical for monitoring complications, managing pain, and ensuring a smooth recovery. Nurses play a key role in assessing, intervening, and supporting both the patient and their family. Two, post-anesthesia care unit, PACU. So we have post-anesthesia unit phases of care. So phase 1, intensive monitoring phase, immediately post-surgery. focuses on airway, breathing, circulation, and consciousness. So ABC and consciousness. Phase 2, immediate recovery phase. Patient becomes more awake, vitals stable, and preparation begin for discharge or transfer. Transfer meaning that it's either for Med-Surg, for instance, or tele. Phase 3, extended care phase, focus on preparing patient for self-care or ongoing care in another unit. The post-anesthesia care unit settings are the inpatient PACU for patients requiring hospital admission after surgery, intensive care unit ICU, used for high-risk patients with extensive procedure or unstable conditions, outpatient PACU for ambulatory surgery. It's a rapid turnover or discharge planning are priorities. And then procedure area recovery used for patient undergoing short procedure under sedation, like endoscopy. And discussing the significance of the postoperative period, we know the postoperative period is divided in 3 phases. So in this chapter, I'm sorry, my dog. And so this chapter I divided on that concept map, but also I go and answer those learning objectives provided by the Davis book. They have their like couple of learning objectives. So this is one of their, actually it's the number one, discussing the significance of the post-operative period. So it's in you find it in this area in the book. So I said already about the immediate recovery phase 1, 2, and 3. So for example, a patient recovering from abdominal surgery in phase 1 needs continuous monitoring for respiratory depression due to anesthesia effects. So the key post-operative priorities is ensuring airway patency, like oxygenation and breathing assessment, prevention complication. It's every time we have to prevent complication like DVT, infection, bleeding. Managing pain and nausea is like administering medication for this. And then supporting early ambulation, reduce risk of blood clots and pneumonia. So it's back to complication of DVT and infection. So this chapter, it's a lot of infection, look for blood clot, look for airway, how the patient can solve the medication, all of these things. 3, patient care in the post-anesthesia care unit. Another learning objective will have like explaining the priority assessment for the post-surgical patient. I will explain this in a bit in the next slide, but first we go by priority assessment. So I think this slide is very important for the NCLEX because it's monitoring vital signs every 15 minutes initially, then as ordered. Assess airway patency, oxygen saturation, and respiratory effect. neurological status, level of consciousness, pupillary response, orientation. And then we have the pain. We have to administer, prescribe opioids, monitor effectiveness. So here is like in NCLEX on that CPR in the candidate performance report says like evaluate outcomes. So here we have administer. So you administer, prescribe opioids, monitor effectiveness. So everything you give or do for the patient, you need to evaluate. It is effective or not. Did the patient tolerate it well or not? Not well. Why? Allergic reaction or nausea and vomiting. So here we have to kind of, it's back and forth. Respiratory depression. Patient control analgesia, so the PCA, teach the patient to use, but this usually, if the patient will initiate, will have a teaching in the post-operative, but also will remind because the under anesthesia kind of lose a little bit like to remember, like, oh my god, that long list that the doctor told me to remember during my phase 1, phase 2, etc. So that's why when we are there, we don't assume the patient was taught already. No, we have to re-explain. And if the patient is like, oh yeah, I know, okay, so we'll do next this, and then you see if still annoying, or you just pop quiz the patient. But sometimes patient will say like, I'm so tired of questioning, so by hearing says teach patient to use monitor for over sedation. Yeah, but this is controlled, so over sedation is not with PCA because it's already medication control, but probably after many times use, patient will not tolerate that amount of opioids in the system overall. Management for nausea and vomiting all the time. Then potential complication. Always we, through this whole chapter, potential complication. Airway, the throat, like the hypoventilation or aspiration. You don't want to see the patient choking. Cardiovascular instability, hypotension, hypertension, arrhythmia. So always we have to look for this. So moving for the same topic. Nursing management in the pack. Oh my god, this is the second time I recall my dog started barking at the mailman. So here we have, as previous we said, about to explain the priority assessment in the post-surgical patient. So nurses perform frequent assessments in the immediate post-operative period to detect complication early. So we always do assessment, action, and teaching, like assessment, head-to-toe assessment, documentation of changes, action, the ABC, so maintain the airway, apply oxygen, teaching, educate the patient and the family about recovery expectation and discharge instruction. So for the airway and breathing, so the ABC approach is like monitor oxygen saturation to detect hypoxia, assess breath sounds for wheezing, stridor, or diminished airflow. So do you know the difference between wheezing and stridor and where are located and why? Make sure there are other more detail about this in and about respiratory chapter in the book. Then we have observe for signs of respiratory distress, cyanosis, agitation, tachypnea. You see, do you notice here that I'm saying about a lot of keywords? So the terminology of tachypnea, cyanosis, hypoxia. Let's think about an example here. A patient with low oxygen, like for instance below 90%, may need oxygen therapy or repositioning, right? Then we have cardiovascular monitoring, like what we do here. We check blood pressure and heart rate for signs of shock or fluid overload. Assess for signs of hemorrhage like low blood pressure, rapid heart rate, pale skin. Also, we monitor for DVT again, right? What is DVT? How we know that? So it's the swallowing, pain in one leg, for instance, redness. So, for instance, a post-op patient with tachycardia and hypotension may be experiencing internal bleeding. C. Neurological assessment. Evaluate the level of consciousness using the Glasgow coma scale. Assess for delayed anesthesia recovery like confusion, slow wake up. Check also for pain levels and response to medication. So response for medication means evaluate the outcome. Again, whatever we give, it's effective, yes or no, and how. Let's think about then. An example, a patient taking longer than expected to wake up, so you might need a neurological evaluation and the glucose check. D, surgical site and drain assessment. So if a patient has those, what do you do for this? You inspect incision for signs and infection, like redness, swelling, pus. Monitor surgical drains for the output. There are all kind of surgical drains like Jackson Pratt or Hemovac. Assess for like a wound, for instance, like the wound opening. It's that for disease sense or evisceration, like where the organs protruding. So imagine if a patient with excessive drainage from a surgical site may have postoperative bleeding. Then lastly, fluid and electrolyte balance. So we need to monitor always for urine output, at least 30 ml per hour. This is the normal to assess kidney function. So they have those at the Foley bag. It's different Foley bag that you can see in a tube. You can measure like how many mLs, and then you will kind of tilt that bag and then goes into the all, and then when you take more notes, like every 2 hours, you put like in 2 hours what happened, or 3 hours. But also you see in that little tube how much since last time you checked. I think you know what I'm talking. Yeah, so check also for fluid retention and dehydration. Assess for electrolytes imbalance like low potassium or sodium levels. You see, like where go again back to potassium. Example, and have you ever noticed that potassium have so low range, like 3.5 to 5? It's like so little range. Then imagine that the post-op patient with decreased urine output may have impaired kidney function or dehydration. So it was a bit of a lot of information here. I hope I don't make you to fall asleep. So let's move in next. So we're moving next. This is patient care on the inpatient unit. We have another learning objective, so it's in here, and the next one about examining risk and complication for the surgical patient. So potential post-operative complication, we have the respiratory. So an example, encourage to use of incentive spirometer and ambulation. Then we have the cardiovascular, again, the DVT and the hypotension. So example, apply the SCDs, monitor for leg swallowing. Then neuro is the delirium or oversedation. So for instance, reorient patient, reduce opioid dosage if needed. Then we have the GI, what is the constipation. For instance, monitor the bulb sounds always when we do the assessment head to toe. After the lungs, you go and listen to the heart, the S1 and S2, bloop, 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 bloop. And then you move to the 4 quadrants of the abdomen. So you monitor the bowel sounds and you start to listen, because after the surgery, the bowels will sound very will take a while, so they say like 5 minutes per each quadrant, and then you say like absent or something, but you start listening and listening. So that we have all the bowel sounds and advanced diet slowly for liquids, sips. Then you go to different type of liquids, which is from clear to little liquids, and then soft diet and more. So that means advanced diet. We have the urinary. Let's think about the kidney retention or infection. Encourage early ambulation and monitor for intake or output. We talked earlier about this, the output. So the integumentary, so the skin pressure ulcer. Example, turn the patient every 2 hours to prevent this, because if it's sitting there and it's so heavy for the patient to you need to help and use pillows when you reposition. Then we have the nursing diagnostics and problems. We don't want problems, but we try to prevent them. So the acute pain, impaired gas exchange, risk for infection, impaired skin integrity. Here at nursing intervention, we have the assessment, ongoing monitoring, early signs of complication. Action, it's implement prevention strategies like, again, early ambulation, turning schedule, teaching, explain activity, restrictions, wound care, and signs of infection. We have always, so it's repetitive, but I think the more we hear it, it's a brain muscle, I think, will help us. For nursing management, it's repetitive in the book a lot, how we develop support strategies for the surgical patient and their family. So we have the nursing diagnostic, intervention, assessment, action, teaching, patient support, family support, evaluation. We all back and forth on these through the chapter. So moving forward, how we apply the viral post-operative intervention for the immediate recovery period. So these are the objectives for this. So families often experience stress anxiety, right, when a loved one undergoes surgery. So we, the nurses, play a crucial role in providing emotional and informational support. So keeping family members informed, like provide frequent updates on the patient condition, explain recovery expectation, like pain, about diet, about movement restrictions, right? You don't go in a marathon right away. Hopefully not. uh, Reassure them about normal post-op changes like drowsiness, nausea. For instance, a family waiting for an update on their loved one after heart surgery, they need clear communication from the nurse. Let's see, be educating family members on post-operative, operative here, operative, post-operative care. So here is like to encourage family member with wound care instruction, like dressing changes, infection signs, medication guidance, pain management, anticoagulants, activity and mobility precaution. Like, for instance, if this patient have a caregiver and taking care for a hip replacement patient, must learn how to assist with mobility safety, right? Then we have the addressing emotional and psychological needs. So this area, it's again NCLEX. So here we encourage signs of post-op anxiety or depression. You see again, anxiety, depression, and then encourage the patient and family to express concerns. Encourage the patient and family to express their concerns. Provide also resources for support groups or counseling. Imagine that a cancer patient undergoing surgery may require, let's say, additional emotional support and counseling referrals, right? Because it's a cancer patient. Then we have to think about again the pain management. How is your pain? Does the patient can talk, can have the faces, in case it cannot say the faces, use the faces. Preventing pulmonary complication. So now when we uh, applying virus post-operative intervention for the immediate recovery period. We have, let's say, post-op intervention help prevent complication and promote faster recovery. So again, they talk about pain management. Pain management is a multimodal approach like opioids, NSAIDs, local anesthesia. And consider that those non-pharmacological methods, positioning, cold therapy, relaxation techniques, this is very, very, very important for Medicare. They like to use non-pharmacological prior you jump and give to an elderly patient opioids. So they like non-pharmacological, and I think it's also in NCLEX. I think when they have in NCLEX, they give you like monitoring or do the action, something like that. There you look for non-pharmacological when you use them. So those little tables that they have in NCLEX, they trick you. So you need to consider this pain management non-pharmacological. Monitor for opioid side effects. Of course, like again, you evaluate, you give them. Do they have, it's good or not? Then the side effects is pharmacological. So here we have like can be a question from that pie into with two meaning, like for pharmacological, right, and basic care. So how is the side effects? Respiratory depression, constipation. Of course, we know it's a side effect. So we give opioid if constipated. So what do you give for constipation? But with constipation for non-pharmacological, it's early ambulation. So also early ambulation is good for other things. So this is like non-pharmacological, and also like liquids, movement, and then you go to the meds. But some doctors, they give right away meds also, so you do all combine, all in one. So imagine that the patient who has a PCA pump should be monitored for sedation and respiratory status. When you give an opioid, always you look for respiratory status. Preventing pulmonary complication, again, encourage for deep breathing and coughing exercises. Use these intensive spirometers to prevent oh my goodness, atelectasis. So here this is like again non-pharmacological, right? And promote early ambulation to reduce risk of pneumonia. But also early ambulation is not just for risk of pneumonia, also for constipation and also for muscle strength, for much more. Ambulation is really good. So imagine if the bedridden patient post-surgery is at high risk for lung infection without proper respiratory intervention. So here for DVT, I'll take my light off. For DVT, again, encourage early ambulation as soon as safe. Use those sequential compression devices, the SCDs, or anti-embolism stockings. Also administer anticoagulants like heparin and enoxaparin as prescribed, of course, as prescribed. So imagine a patient recovering from knee surgery should wear the compressing stocking, right? Why? to prevent those clots. Then we have this monitoring for post-operative nausea and vomiting. So we administer like Zofran. This is the very popular as needed PRN. Depends of the provider. They might say 4 milligrams, 8 milligrams. You just pay attention there. Encourage slow oral intake progression, like clear liquids first. We also assess for dehydration if vomiting occurs. Why? Vomiting means like you lose fluids, and then the vitals goes off the roof, and you have to look for the vitals. So imagine a patient vomiting post-op may need IV fluids to prevent the dehydration. So I think that lastly we have here for the wound healing, how we promote this. And we need to ensure proper nutrition, like high protein, vitamin C and zinc, but this is like narrow way. High protein, but this is come in the IV, but we don't let's have a steak. Monitor for signs of infection like fever, redness, warm. Provide proper dressing changes and wound care, and you do also as needed. Even the doctor says like every other day or every day. Also, it's as needed. When the dressing gets soaked, you look and you report to the doctor what you see and why you think it's needed this PRN wound change, and the doctor needs to know right away. So imagine that your patient is diabetic, so that obviously why is he this person diabetic patient might be at the risk or higher risk for poor wound healing, and must control the blood sugar level post-operatively. So then we go next on learning activity objective for this chapter. We have the evaluating post-operative intervention on the inpatient unit. So after the initial recovery period, nurses continue to monitor progress, adjust intervention, and ensure readiness for to be ready for discharge. So we have to assess the readiness to be ready for discharge, like what? To have the stable, no, within normal ranges, the blood pressure, heart rate, respiration, so with normal limits. Then we have the pain control with oral medication. So that's why when it's discharged, it's ready to have the oral medication. Patient is able to eat, drink, and urinate, right? So he could be discharged. Also is no active bleeding, nor signs of infection. For instance, a patient who cannot tolerate fluids or manage pain should not be discharged yet. So will be just moved to different department. Then be evaluating effectiveness of nursing intervention, and think about did the patient ambulate as planned? Is the pain well managed without excessive sedation? How or has the wound healed without infection? You know, like kind of to be the base. Imagine if the patient oxygen level remained low. Additional breathing exercises and oxygen supports might be needed, right? And here we have like the nursing implication. It's back and forth from like either it's from inpatient unit or ICU or PACU. So always we look for the lab values trends. Glucose might be elevated due to stress. Again, you see the labs might drop post-op, which is normal, but see how is it. We talk about infection. The white blood cells can be elevated from inflammation. Watch. So watch for fever. Then again, you see like sodium, potassium, magnesium might shift. The post-operative teaching, again, teaching for sinus infection, incision care, pain, DVT, the meds at home, diet and hydration, activity and restriction, and of course, follow-up appointments with the surgeon. So will be given, the surgeon will say, okay, I want to see you go home now, and I see you, let's say, in a few days. Or, and then also you need to have with their primary providers, or because they need to know, and they need to follow up that too. Yoo-hoo! Oh, we made it! It's summary finally. So why this chapter matters, right? Early detection complication, save lives, proper pain and nausea management, improve recovery outcomes, patient and family education, reduce anxiety again, and ensure safe discharge. And here we talked about significance of postoperative period, the three phases, phase 1 in the PAC, phase 2 continue monitoring, and phase 3 long-term healing. And then priority assessment, again, vitals, airways or ABC, bleeding, surgical site, pain, but also pain is because can be from surgical side, but also pain because it's infection on the side, fluid imbalance and neuro status. Then of course you need to support the family of the person in charge of the patient, providing updates, educate the post-op care, and addressing emotional needs. This is very important. You'll be asked in NCLEX for emotional support because nowadays it's a really big deal. The virus intervention is like, again, pain control. It was, how is the evaluation? Is good or bad? Or DVT prevention, right? Ambulation and those devices. Infection control, respiratory support and wound care, then evaluating recovery. The base within certain virals to be kind of stable, not off the roof. You don't want to send home a patient with blood pressure systolic 200. over 100. No, you don't send it home with 200 over 100. You have at least to be like 136 over, I don't know, even 90. It's okay. No infection, proper wound healing, control pain. So patient can take pain meds around the clock, and he can be able to function. Minimal to improving in functioning, and discharge readiness. Make sure that here they can be tricky if you send it home, if if a patient didn't do yet a bowel movement. Here a surgeon will let you know if it's okay to be under medication, or on certain days to report, or it's not mandatory if you have a bowel movement, it's not transferred. So depending the surgeon. So follow the surgeon instruction for the bowel movements, but the urinary output, it's always mandatory to look for it. Okay, so I think that's it for this chapter. Thank you so much for being here with me today. I hope this video helped make things feel a little clearer and less overwhelming. If this supported your learning, please give it a like or share it with your fellow nursing student who might need this too. Everything we cover connects back to the real nursing, whether it's recognizing a lab, planning safe care, or knowing what to teach a patient. Let me know in the comments below, what was the most helpful thing you learned today? What still feels unclear or confusing? If this was what you hoped, and make it easy for you. If you can also let me know if you like the notes for this chapter. Check the description. I usually add some free resources there just for you. Thank you again for your time and trust. I'm Nurse Mia, and from my heart to yours, until next time, stay zen, stay grounded. Namaste. Bye for now.